Imagine sitting in a doctor's office, waiting for 30 minutes while you go completely numb.
Yeah, just staring at the ceiling.
Right. And you're just sitting there knowing a clinician is about to inject a highly concentrated serum of your own blood directly into, well, the most sensitive nerve endings in your entire body.
It sounds objectively terrifying.
It really does. But thousands of women are actively seeking this out. They're booking appointments for a procedure known as the O shot, or the orgasm shot.
And that name alone, well, it does a massive amount of heavy lifting. It immediately sets this incredibly specific, highly marketed expectation for anyone walking into that clinic.
Oh, absolutely. And because of that marketing spin, we decided we really needed to pull a massive stack of sources for today's deep dive, just to figure out what is actually happening in those treatment rooms.
Because the contrast is huge, right? We're balancing subjective, glowing patient enthusiasm against some very rigid, dry clinical data.
Right, exactly. So we've got clinical reviews, patient information leaflets from the ACE group, and systematic reviews from major medical journals like the Cochrane Library and Frontiers in Medicine, plus a bunch of detailed clinic FAQs.
It's a polarizing stack of information, for sure.
It is. So our mission today is to just completely strip away the glossy brochures. We want to look at the stark clinical reality of the O-shot.
Because if you're listening to this, you might be, intensely curious about it, but you're also probably pretty intimidated.
Totally. You're probably dreading that overwhelming Google search that just throws conflicting medical jargon at you. So we are focusing heavily on the physical experience today. We want to answer the burning questions you actually have.
Like, does it hurt?
Yes. Does it hurt? And how on earth do they use anesthetic for something involving the clitoris and the vaginal walls?
I mean, it is entirely normal to want a vivid step-by-step understanding of a medical procedure before you even consider opening your wallet, or even booking a consultation. You need to know the mechanics.
Right, before you can weigh any of the benefits. So let's start with the syringe. Because before we can even touch on pain management, we really have to look at what is being injected.
Yeah, the sources are very clear on this. This isn't Botox.
No, and it isn't a synthetic filler like hyaluronic acid that you might get in your lips or your cheeks.
Right. There are 0 synthetic materials used. The O-shot is an autologous procedure, and in medical terms, autologous just means the donor and the recipient are the exact same person.
Which is fascinating.
It is. It relies entirely on platelet-rich plasma, or PRP, which is harvested directly from your own bloodstream.
So I was reading through the clinical guidelines, and they frequently reference this thing called the Golden VAC protocol for the extraction. But from a patient's perspective, this just looks like a standard blood test at first, right?
Yeah, a standard blood draw is exactly how it begins. The clinician takes blood from your arm, usually anywhere from 10 to 40 cubic centimeters, depending on the clinic's specific protocol.
Okay, so decent-sized vial.
Right. And that blood goes into a vacuum tube that contains a small amount of sodium citrate that just acts as an anticoagulant so the blood doesn't clot while they're handling it. Then, that vial goes straight into a specialized medical centrifuge.
And a centrifuge is, well, it's essentially a machine that spins the vial at incredibly high speeds, right? To separate the liquids based on their physical density.
Exactly. The Golden VAC system mandates spinning the sample at 3,000 RPM for exactly 10 minutes.
Wow, that is fast.
It is. And the centrifugal force is so intense that the blood physically fractures into 3 distinct layers. The heaviest elements, which are the red blood cells, they sink straight to the bottom.
Makes sense.
And the lightest element, the platelet-poor plasma, which is mostly just water and proteins, floats to the very top.
But the prize is what's trapped right in the middle. The sources call it the Buffy coat, which it sits right above a specialized separator gel in the tube.
Yeah, that Buffy coat is tiny. It's roughly a 4 cubic centimeter layer, but it contains this massive concentrated dose of your blood's platelets and growth factors.
Right. So to picture how this works, think of your bloodstream as this massive construction site.
Yeah.
Your red blood cells are like the thousands of general laborers just carrying oxygen around, doing the heavy lifting.
I like that analogy.
Yeah, but the platelets in that Buffy coat, those are the master architects and the foremen. So by spinning the blood, you're essentially pulling all the architects out of the crowd.
You're leaving the laborers behind.
Exactly. You leave them behind so you can inject pure, concentrated instructions directly into a failing building, or in this case, aging or damaged tissue, telling it to rebuild.
That is a perfect way to visualize the cellular mechanics. You are isolating the biological signaling mechanisms, and actually in some clinics, they'll add calcium chloride to that extracted PRP right before the injection.
How to activate it.
Exactly. It acts as an activator. It tricks the platelets into thinking an injury has occurred, which causes them to just dump all those architectural instructions, the growth factors, into the tissue immediately.
Okay, now, despite the fact that blood is drawn, processed, and re-injected, the regulatory frameworks classify this very distinctly. In the UK, for example, the sources note the O shot falls under the amber tier.
Right. The amber tier designates medium-risk, non-surgical procedures. The red tier would be reserved for actual surgery in an operating theater.
So no scalpels here.
No scalpels, no general anesthesia, no stitches. The entire process takes place in a standard office setting and usually wraps up in under an hour.
Wait, hold on, though. The sources classify this as medium risk, but we are talking about injecting your own body's material back into itself. You can't be allergic to your own blood, so shouldn't that be practically zero risk?
Well, while the autologous nature does eliminate a risk of an allergic reaction or tissue rejection, the physical act of puncturing the skin always carries inherent risk.
Oh, just the needle itself.
Right. The moment you introduce a needle to a sensitive anatomical structure, you open the door to localized infection, temporary swelling, or, minor trauma to the injection site.
Yeah, that makes sense.
And the medical literature also notes the rare possibility of nerve injury, which could cause a temporary altered sensation. So the material is safe, but the delivery mechanism is where the clinical risk resides.
Okay, so we have this incredibly potent, concentrated serum of architects ready to go.
Right here.
But extracting it from your arm is one thing. Injecting it back into highly sensitive tissue, like the clitoris and the upper vaginal wall, is another entirely.
Yeah, the pain management for that must be intense.
The fear of pain is definitely the primary barrier for almost every patient considering this. But the clinical reality is heavily managed by a very robust, multi-step numbing protocol.
I was actually reading the clinical protocol, and it mentions a 30-minute soak with a 2% lidocaine or a lidocaine-prelocaine mix. Is that standard? Because 30 minutes seems like a really long time to just sit there in a clinic without your pants on.
It is absolutely standard, yeah. And the duration is critical to the pharmacology of the anesthetic. This isn't just a quick numbing spray.
Right, it's a cream.
Exactly. A thick layer of medical-grade topical cream is applied directly to the vaginal walls, the clitoris, and the labia. Lidocaine works by temporarily blocking the sodium channels in the nerve endings.
And when those channels are blocked, the nerves physically cannot fire off the electrical signals that tell your brain you're experiencing pain.
Yes, but penetrating mucosal tissue and reaching those deep nerve endings, that takes time.
So you really are just sitting there reading a magazine while your entire pelvic region slowly goes offline.
Pretty much. And some clinicians will even supplement the cream with a localized anesthetic block, similar to the injection a dentist gives you before a filling, just to ensure the area is entirely desensitized.
Wow. Well, the patient reviews in our sources actually back up how effective this is. One review specifically highlighted that the numb feeling was the weirdest part of the whole process.
Yeah, I saw that quote.
She said she literally felt nothing during the actual injections.
Because complete sensory blunting is the clinical goal before the needle ever approaches the tissue.
Well, let's talk about that needle. Because, the word needle combined with the word clitoris triggers an immediate, very visceral reaction.
Understandably so.
What is the actual clinical technique happening while the patient is numb?
So the provider uses a 31-gauge needle. For context, gauge sizes run inversely to their thickness, so a 31 gauge is microscopic.
Oh, okay.
Yeah, it's roughly the exact same size as the fine needles diabetics use for daily insulin injections. It's designed to be as atraumatic to the tissue as physically possible.
And where are they placing this microscopic needle?
If the treatment is targeting sexual function, the clinician creates what the medical literature calls a circumferential ring of blebs.
A ring of blebs.
Yeah, bleb is simply a tiny, superficial, fluid-filled blister beneath the skin. They make these microscopic injections in a circle around the clitoris, typically at the 12, 3, 6, and 9 o'clock positions.
Subdermally, right, like just barely under the surface.
Yes, very shallow. Now, if the patient is there primarily for stress urinary incontinence, the technique shifts a bit. The clinician injects about 5 to 6 milliliters of the PRP periurethral.
Periurethral. meaning into the tissue immediately surrounding the urethra. I think the sources mention injecting into the submucosal plane.
Exactly. The submucosal plane is essentially the deep, supportive layer of tissue just beneath the surface lining of the vaginal wall. By injecting the plasma there, the goal is to bulk up and regenerate the tissue that physically supports the urethra.
Even with the 30-minute numbing soak, what is the actual sensation reported by patients when that 31-gauge needle goes in?
The overwhelming consensus from the clinical data is that the injection feels like a slight pinch, followed by a warm sensation or a feeling of deep pressure as the fluid actually enters the tissue.
And how long does that take?
The actual active injection phase of the appointment takes only 5 to 10 minutes to complete.
That ratio is wild to me. 30 minutes of intense numbing preparation for just 5 minutes of actual medical intervention?
It really highlights just how sensitive the anatomy is. You cannot rush the pharmacology of the lidocaine if you want a compliant, comfortable patient.
So the 5 minutes are up, the needle is gone, you walk out of the clinic, and as the leaflets point out, this is a walk-in, walk-out procedure with 0 surgical downtime.
Yep, you can get dressed and drive yourself back to work.
But what happens an hour later when those blocked sodium channels wake back up and the lidocaine wears off?
Well, you will experience some physical feedback from the tissue. Patients commonly report mild dysuria over the first day.
Dysuria meaning a slight burning or discomfort when you urinate.
Yes. There is also a pronounced feeling of pelvic fullness or heaviness. You have to remember, the clinician just introduced several milliliters of fluid into a very tight, enclosed anatomical space.
Right, it creates pressure.
Exactly. Minor spotting or a few drops of blood on toilet tissue for the first 24 hours is expected, and localized soreness or swelling can linger for 1 to 3 days.
Now, here is where the clinical leaflets presented a massive paradox that caught my attention.
Oh, the painkiller rule.
Yes. Normally, if I have any sort of medical procedure and I'm dealing with soreness and swelling, my immediate reflex is to reach for a bottle of ibuprofen or Advil.
Of course.
But the ACE group guidelines have a bolded warning. They say, do not take non-steroidal anti-inflammatory drugs or NSAIDs for a full week before or after the procedure.
It seems so counterintuitive.
Right. If you are actively experiencing swelling and discomfort, why are you forbidden from taking the most common anti-inflammatory painkiller on the market?
Because taking an anti-inflammatory drug fundamentally sabotages the exact biological process you just paid to initiate. We have to draw a line between chronic inflammation, which damages your body over time, and acute inflammation, which is the necessary spark for tissue regeneration.
Explain how that spark works with the PRP we just injected.
So when those concentrated platelets, the architects from our earlier analogy, are injected, they need to sound an alarm to bring in the rebuilding materials. They do this by triggering an acute inflammatory response.
Ah, I see.
And that inflammation causes the platelets to release specific cellular signals, known as growth factors. The 3 major ones are VEGF, EGF, and PDGF.
Let's break those down. What do those acronyms actually do inside the vaginal tissue?
Sure. So VEGF stands for vascular endothelial growth factor. Its primary job is angiogenesis. It literally instructs your body to sprout brand new microscopic blood vessels to feed the tissue.
Wow.
Yeah. Then EGF is epidermal growth factor, which forces the rapid replication of new skin and mucosal cells. But here's the catch. None of these signals get broadcasted without that initial inflammatory alarm.
So if you swallow an ibuprofen because you feel a little sore.
You shut off the alarm.
Oh, no.
You chemically freeze the healing cascade. The NSAID reduces the inflammation, which suppresses the release of the growth factors, and suddenly those concentrated platelets you just injected have absolutely no way to communicate with your stem cells.
You essentially turn your expensive regenerative treatment into a completely useless pocket of fluid.
Precisely. If a patient is in genuine discomfort and requires pain relief, the strict clinical protocol is to use paracetamol, which is commonly known as Tylenol.
Because it works differently.
Right. Paracetamol works centrally. It changes how your brain perceives pain signals, but it does not reduce inflammation out in the peripheral tissues.
Okay, so take paracetamol, endure a couple of days of pressure, and observe a 24-hour pelvic rest, which is the polite medical term for abstaining from intercourse to let the injection sites close.
Exactly.
Beyond that, your normal life resumes immediately. But that brings us to the ultimate reality check. Why tolerate the needles, the numbing, and the swelling? How exactly does sprouting new blood vessels treat the wide variety of conditions clinics advertise this for?
Well, the clinical mechanisms vary depending on the diagnosis. The sources highlight 4 primary conditions patients seek the O-shot for. The first is stress urinary incontinence, or SUI.
which is the involuntary leakage of urine when you laugh, cough, or jump. Right.
Wow.
Often resulting from weakened pelvic floor structures after childbirth or just aging. And how does injecting plasma fix a leaky valve?
For SUI, the growth factors are tasked with building new collagen and elastin in that submucosal plane we discussed earlier. It's an attempt to physically bulk up and tighten the tissue supporting the urethra, providing a stronger backstop to prevent leakage.
Okay, that makes mechanical sense. The second condition mentioned is lichen sclerosus.
Yeah, this is a chronic, often incredibly painful autoimmune condition that causes severe thinning, itching, and structural tearing of the vulvar skin. The systemic reviews note that PRP shows great promise here because the EGF, the epidermal growth factor, helps thicken and regenerate that damaged paper-thin mucosal tissue.
The third is genitourinary syndrome of menopause, or GSM, which involves severe vaginal dryness and tissue atrophy due to dropping estrogen levels.
Exactly.
And the final condition is female sexual dysfunction, FSD, which encompasses low arousal or an inability to reach orgasm.
Right, and for GSM and FSD, the primary mechanism is angiogenesis. By forcing the body to build new capillary networks, you drastically increase blood flow to the clitoris and vaginal walls.
And more blood flow means increased natural lubrication, better engorgement during arousal, and heightened sensitivity in the nerve endings.
But, and this is a big but, the marketing brochures often frame this as an overnight miracle, like walk in with dysfunction, walk out cured. Our sources very explicitly debunk that instant magic myth.
Yeah, the data reveals a really fascinating psychological and physiological split. About 50% of women report an instantaneous wow effect within 24 hours of the procedure.
But the biology we just walked through tells us that angiogenesis and collagen production take weeks. So how are they feeling better the next day?
It is largely a combination of the placebo effect and the physical reality of the injection. You just pumped several milliliters of fluid into the tissue, creating artificial engorgement.
Oh, that makes sense.
Plus, the minor trauma of the needle naturally increases local blood flow, but for the other 50% of patients, day zero yields absolutely no subjective change.
So if a listener gets this done and feels nothing on day 2, they need to know that is biologically normal.
Very normal.
What is the actual timeline for the results?
The true biological timeline is a slow, steady burn. Days 3 through 7 are the early phase, where patients might notice the first subtle shifts in natural lubrication as the inflammatory cascade peaks.
And then the remodeling phase begins.
Yes, the cellular remodeling phase takes several weeks. This is the period where old, disorganized tissue is being actively replaced by fresh, elastic collagen, and those new microscopic blood vessels are maturing.
So it's a process.
It is. Peak efficacy. The absolute best result you're going to get from the shot doesn't hit until roughly month 3.
And are those month 3 results permanent? Like, have you permanently reversed the clock?
Well, no. You have improved the tissue quality, but you haven't stopped the aging process. The clinical benefits generally persist for 12 to 18 months as the body continues its natural degradation. After a year or so, maintenance sessions are usually required to sustain the physiological gains.
Right. And this is where we really have to introduce the major clinical caveat. Our mission is to keep this evidence-based, and that means looking at how the wider medical community views this.
Definitely.
We have numerous small studies showing fantastic subjective improvements. Women fill out the Female Sexual Function Index questionnaires and report significant drops in pain and massive improvements in arousal and continence.
Yeah, the subjective patient satisfaction rates in these localized studies are undeniably high.
And yet major regulatory bodies, like the NHS in the UK and the Lynos guidelines, do not endorse the O-shot as a frontline treatment. The sources clearly label this as an investigational or off-label use of PRP. Why is there such a disconnect between happy patients and regulatory approval?
Because the gold standard of modern medicine is the large-scale, long-term randomized controlled trial, or RCT. Regulatory bodies need massive data sets proving that a treatment is objectively superior to a placebo or to existing proven therapies across thousands of diverse patients.
And those just don't exist yet.
Those massive RCTs simply do not exist yet for the O-shot.
Yeah, the sources specifically cite the Dinesh Praju study regarding stress urinary incontinence as an example of this.
Right. That study directly compared PRP injections against the traditional surgical intervention, which is a mid-urethral sling for women with severe incontinence.
And what did they find?
The objective data showed that the surgical sling remained vastly superior for resolving the issue.
Which makes sense based on the mechanics, right? If a patient has a severe structural failure, like a major pelvic organ prolapse or a deeply compromised urethra, A few cubic centimeters of blood plasma isn't going to magically stitch torn muscle back together.
Exactly. PRP is a biological intervention, not a structural one. Surgery remains the definitive gold standard for severe anatomical issues.
It is paramount that clinicians provide this reality check during consultations. Patient expectations absolutely must align with what the biology is actually capable of delivering, otherwise disappointment is pretty much inevitable.
So let's pull all of this together. We've traced the journey of the O shot from the initial blood draw to the centrifuge, isolating those master architects in the Buffy coat.
We've explored the intense 30-minute topical numbing protocol that temporarily shuts down the nerve's sodium channels, which allows a microscopic 31-gauge needle to safely deposit the plasma into the clitoris and submucosal tissue with minimal pain.
And we also uncovered that critical post-procedure paradox, the absolute necessity of avoiding anti-inflammatory drugs like ibuprofen.
Right. Ensuring the body's natural inflammatory alarm can trigger the release of growth factors for angiogenesis and collagen building.
Recovery is swift, with only minor pressure and spotting, but patience is mandatory. True cellular remodeling takes up to 3 months to hit peak efficacy, and even then, it's an investigational treatment that bridges the gap between basic pelvic floor exercises and major invasive surgery.
By understanding this physical reality, you really strip the procedure of its mystery. You aren't just blindly trusting a brand name. You are making an informed decision about initiating a very specific biological cascade in your own body.
And that level of clarity is incredibly empowering. It cuts through the murky marketing mud of intimate aesthetics.
It does. But digging into the deep mechanics of extracting our own growth factors leaves us with a fascinating, almost science fiction level concept to consider.
Yeah, it forces us to look at the economic and ethical trajectory of regenerative medicine. I mean, if the ultimate cure for our aging tissue, our pain, and our dysfunction is already locked inside our own veins, just waiting to be spun out in a centrifuge, who exactly owns the future of that medicine?
That's a great question.
Are we moving toward a healthcare system where treatment isn't defined by the synthetic drugs we buy from a pharmaceutical company, but rather by who holds the patent on the machine that harvests our own biology? Will the medicine of the future just be a highly monetized reflection of ourselves?
A highly monetized reflection of ourselves that is a brilliant and honestly slightly unsettling thought to mull over. Keep asking the hard questions, keep digging past the marketing spin, and thank you for taking this deep dive with us.